Bill, you've done a lot of work in clinical trials over the year. I think you have a good finger on the pulse of what's to come. I guess what other novel agents are in clinical trial now, and how do these drugs work? And, maybe focus on two or three of your top hits for what you think is to come.
I think there's three classes of drugs that are farthest along and perhaps have the most promise. One is, and Marla alluded to this earlier, the pure anti-interleukin 23 antibodies, or anti-P19 antibodies. There are multiple of those in development: risankizumab, mirikizumab, brazikumab, and guselkumab. So and they're being studied for the most part in both Crohn's disease and ulcerative colitis. We have less information in ulcerative colitis, but in Crohn's disease, there are now 3 trials in heavily or entirely anti-TNF failure patient populations that show really solid rates of clinical and endoscopic response and remission. So I think that class of drugs for anti-TNF failures is going to be very good. And they are really revolutionary in psoriasis. They're better than anti-P40 drugs. So they will fit all those dermatology indications in our field as well. I think they're not thought to be of great utility for arthritis. So they're sort of like super potent ustekinumab, I think. So that class of drugs is very interesting for Crohn's disease and evolving for ulcerative colitis. Then you have the selective JAK1 inhibitors. So tofacitinib is a pan-JAK inhibitor, only works at the doses that were studied in ulcerative colitis and comes with some safety considerations. My general feeling is that with the selectivity on JAK1, you can essentially go to doses that would be equivalent to much higher tofacitinib doses because of the selectivity. So for the same or better safety, you get more potent JAK1 selectivity, and it's as if you were giving mega dose tofacitinib, which you could never give from a safety perspective. So we have a couple drugs in development now, upadacitinib and filgotinib, in that arena, and they look, interestingly, really good in refractory Crohn's disease. So that will be another option, an alternative to the anti-P19s in the future that are oral. And then you see this nice dose response with upadacitinib and ulcerative colitis. So you get really nice effects as you push up the doses with JAK1 selective drugs. And they have a good arthritis effect. They've got a reasonable psoriasis dermatology effect. So that, that's kind of a useful class. And then the ones that are new will be the S1P modulators. Ozanimod finishes clinical trials this summer, so we should see data this fall sometime with the phase 3 program in ulcerative colitis. There's also emsilimod and etrasimod that are in development for IBD, so at least 3 drugs in that class. As was noted earlier, they work as well in multiple sclerosis. They're being evaluated for atopic dermatitis and some dermatology indications. So that class of drugs, I think, is oral, and it looks like a really good maintenance of remission drug that's oral. So that'll be interesting to see that play out. So to me, those are the 3 big classes. There are some topical plays. So there's a topical JAK inhibitor. It's a pan-JAK inhibitor, but with very little systemic absorption that's being tested in ulcerative colitis and Crohn's disease. It was recently published, a 4-week sort of translational medicine study that showed that you could accumulate drug in the target tissue and affect phosphostatin 3 signaling, which tells you you're blocking JAK in the tissue. It's too short and too small of a trial to see what the full magnitude of the efficacy is going to be. But if you can get, with longer dosing, if you can get full JAK inhibitor efficacy with topical therapy, that'll be really cool. We'll have to see about that.
Great. Well, so Bill, thank you. I knew I called on the right person to ask this question because that was a wonderful overview. And I think for our patients, there's great hope, not only for more selective therapies, but new MOAs coming out down the line.
And one more thing not to forget is additional selective anti-integrin agents. So we have trelizumab that blocks beta-7 and anti-MAdCAM-1 antibody, and those are also in late phase clinical trials and would be, other drugs in the general vedolizumab class. So those are coming too.